Sorry, I'm going to put my other glasses. How are you?
I'm good. How are you?
Thank you so much for being here.
Yeah, you're welcome.
We are anxious to see, and thank you for sending me the mail because I was like, I am arriving. Okay. Do you want to present yourself, or would you like to me to introduce
Sure.
you?
Yeah, that's fine.
Please, just introduce yourself.
Okay. Are there others on or is it just us?
No, it's just us.
Oh, okay. Oh, so is this a recording or?
It's a recording. We are
Oh,
we are recording it.
okay,
Uh,
perfect.
It's
Okay.
recording. Yes.
Can you see my slides or no?
Yes, I can see your file perfectly.
Okay.
Explain function in children progressing to stage one, stage three versus stage three type 1 diabetes. Is it
Yeah,
okay?
perfect. Do you see the presenter view or do you see the normal view?
The normal view.
Okay, good. Okay. I'm just making sure. Okay, yeah, I can go ahead and start. Hello everyone. I'm Brittany Bruggeman. I'm a pediatric endocrinologist at the University of Florida in Gainesville. And I do quite a bit of type 1 diabetes research, but my main focus that's funded by the NIH and others is looking at the exocrine pancreas in type 1 diabetes and whether it's impacted in the preclinical period or post-clinically and how that influences the pathophysiology and also clinical care of patients with type 1. So excited to present my research to you all today.
Yes, of course.
Okay, so I guess I'll go right ahead.
Okay. Thank you.
Okay, so today I'm going to be talking about some work that I did looking at exocrine function in children progressing to stage 1 versus stage 3 type 1 diabetes.
Okay, perfect.
And I do have research funding to our institution from Genti Bio and Mankind, but we'll not be talking about anything related to those studies today.
Okay. Okay.
So before going over our research, I wanted to put it in a bit of historical perspective for everyone. So these are some of the typical type 1 diabetes milestones that I think we're familiar with. Most of us think of type 1 diabetes as a disease of the islets. And so we are looking at the discovery of insulin and autoimmunity as a cause of type 1, and then our first type 1 immune therapy trial and first FDA approved disease modifying therapy in teplizumab. However, we've known for a long time that the exocrine pancreas is also impacted in type 1 diabetes. The prevailing thought used to be that these changes were a consequence of diabetes rather than part of the pathophysiology itself. But in 2012, Martha Campbell Thompson, who's a member of our research group here at UF, discovered that the pancreas overall weighs 25% less in autoantibody positive non-diabetic organ donors. And so that was very interesting to people because this is before the onset of clinical disease and presumably potentially before the loss of beta cell function. And so people started to think maybe exocrine function played more of a role in type 1 pathophysiology than we had previously thought.
Yes, of course.
So, my study was looking at the natural history of exocrine loss in the pre-type 1 diabetes period within the TEDdy cohort. And this is a large birth cohort study that was in the United States and Europe. And we followed fecal elastase, which is the most widely used clinical marker for exocrine insufficiency, throughout the course of the pre-type 1 diabetes period. And we asked three questions. So, first, does exocrine dysfunction begin before islet autoimmunity? Second, is it different in children who progress either to stage 3 very early or children who progress only to stage 1, but don't go on to develop stage 3 in the early childhood time period? And third, can fecal elastase help predict disease progression? So we performed a nested case control study of fecal elastase throughout the pre-type 1 diabetes period within TEDdy.
Excuse
We
me,
had two
could you,
cohorts. Oh,
excuse
yeah.
me, could you do it a little bigger? Maybe, I don't know if it's it's something that you could put to put slide a little bigger? I don't know if you can.
Oh yeah, so you're seeing
I'm
are you seeing
seeing
presenter view or
not a presenter view, the one that you have all you have written downstairs.
oh the notes. Yeah, yeah, yeah. Let me go ahead and I think I can switch that. Um, one second. There's a way to switch it. I should have to figure it out. Here we go.
Maybe
Display
if you can,
setting.
otherwise it's okay.
There we go. Did that work?
Okay. Yes, yes, perfect.
Okay, great. Do you want me to start
Better,
over
better.
or do you want me to just keep going?
Oh, no, you can continue. It's
Okay,
okay.
perfect. Okay. All right, so we performed a nested case control study of fecal elastase within the pre-type 1 diabetes period in TEDdy. We analyzed over 4,500 stool samples, so it was a very large cohort, and these were longitudinal analyses from birth all the way through the development of stage 3 type 1 diabetes. So in cohort A, we followed patients all the way from an average of 3 months of age at the beginning, all the way out to development of stage 3, which was about 19 samples per subject longitudinally. And then in cohort B, these were so cohort A were the fast progressors to stage 3. So these individuals developed stage 3 type 1 diabetes quite early, whereas in cohort B, they developed stage 1 type 1 diabetes, so multiple positive islet autoantibodies quite early, but did not develop stage 3 before, around age 10 or so. So they had positive autoimmunity, but didn't develop dysglycemia for some time. And so cohort B, we analyzed about 23 samples per subject, starting around age 3 months of age out to a year past their development of islet autoimmunity or stage 1 type 1 diabetes. And we hypothesized that fecal elastase would be reduced even before stage 1 in cohort A, so these early progressors to stage 3 type 1. And we predicted that the rate of decline could predict stage 3 onset. So we could use fecal elastase as a marker of early progression. And that we also thought that fecal elastase would be less impacted in cohort B. So here is our table 1 for cohort A. As expected, the cases and controls were generally well matched. There were a few differences though. So the major differences were the clinical center distribution. So more cases came from Georgia, Finland, and Germany. And HLA risk, so more cases had high risk DR3, DR4 HLA. Cases developed stage 1 quite early, like I mentioned. So stage 1, they developed at around 18 months of age on average, and stage 3, they developed around 30 months of age. So they already had clinical type 1 diabetes by 30 months of age, so very young. And the vast majority of them developed all 3 positive islet autoantibodies. Cohort B was very similar. So cases developed stage 1 a bit later than cohort A, which makes sense as they were a bit slower progressors. And so they developed stage 1 around 30 months of age. So still quite young, but a bit later. And then they didn't develop stage 3 until around 10 years of age on average. And so they had a long period of time where they were in stage 1 type 1 diabetes before developing stage 3. And overall, more of these cases presented with single autoantibodies, so insulin, GAD, and IA2, and then in cohort A, who had mostly multiple islet autoantibodies. So to start with cross-sectional findings, in cohort A, who were the early progressors to stage 3 type 1 diabetes, what surprised us most was that a difference in fecal elastase was already present at baseline. So at that, it was a median actually of 4 months of age. They already had a difference in fecal elastase, so lower fecal elastase in these early progressors at baseline. And then there were further declines in fecal elastase compared to controls at stage 1, type 1 diabetes, and then stage 3. As a reminder, just for people who don't do exocrine insufficiency very often, which is, I think, most of us, clinical exocrine insufficiency doesn't occur until fecal elastase is less than 200. And this was very rare overall in this cohort. So only about 2.7% of cases and 1.1% of controls had a range that would be considered indicative of clinical exocrine insufficiency. So this was all mostly subclinical. And then in cohort B, who were these later progressors to stage 3, but early progressors to stage 1, there were no cross-sectional differences between cases and controls, either at baseline or at stage 1 onset. Next, we asked whether fecal elastase changed over time. So we looked at linear mixed models for log transformed fecal elastase and adjusted for HLA, clinical center, sex, and age, with time centered around the development of stage 1 or stage 3. And in these early progressors to stage 3, fecal elastase did decline both before and after the development of stage 1 type 1 diabetes, and then declined before the development of stage 3 type 1 diabetes. In contrast to those early progressors, among the children who developed autoimmunity but were free of dysglycemia for a long period of time, they did have some decline in fecal elastase, but the signal was much weaker than in cohort A. And then finally, we were looking at prediction of the development of stage 3 type 1 diabetes. So basically, we were trying to ask if you measure a fecal elastase at stage 1, does that predict stage 3 development of type 1 diabetes within 2 years? Because that was about the median difference in time between our two cohorts. And overall fecal elastase was a modest predictor. So it did not do very well on its own in terms of prediction. So the AUC of the ROC curve was 0.57 to 0.62, which is, I would say, poor in terms of prediction. However, we tried to then combine it with first presenting autoantibody to see if it worked better as a combination marker potentially. And that did improve the AUC under the ROC curve. And so if you looked at first presenting islet autoantibody by itself, that AUC was 0.64. And then if you combine that with the fecal elastase level at stage 1, the prediction improved to 0.71, which is still not great, but is more in the moderate range for prediction. So overall, fecal elastase was reduced even in infancy and declined. The decline was more pronounced in these early progressors to stage 3 type 1 diabetes. So this kind of tells us that exocrine dysfunction can't be just a consequence of clinical type 1 diabetes. If in these early progressors, they already have changes even before the development of stage 1. Overall, though, the rates of exocrine insufficiency were very low in this preclinical population. So I don't think we necessarily need to worry about clinical exocrine insufficiency in patients who are in the stage 1 and 2 time period. If you look at other studies, there are higher rates of exocrine insufficiency, like clinical exocrine insufficiency in established type 1. So I do think we should still consider testing a fecal elastase in people who have established type 1 and concerning symptoms for exocrine insufficiency. So those can include like bloating, fatty or greasy stools, weight loss, those sorts of things. So especially if you get back like a negative celiac panel and they're still having symptoms that are concerning, considering screening in established patients. But in these like kind of pre-type 1 patients, it doesn't seem like it's common at all to have clinical levels. And then fecal elastase was a modest standalone biomarker of progression, but it might improve risk prediction when we combine it with established markers like autoantibody positivity or potentially other metabolic markers that we haven't looked at quite yet. And that's it. And I'm happy to take
Yes.
your questions. And this is the research team. Thank you so much.
Oh, thank you so much for being. You know that I went to Gainesville. I was in Gainesville with Desmond Schatz and everybody a
Oh,
long
he's
time
wonderful.
ago.
He's one of my
And then,
mentors.
and then yes, and with Janet Silverstein and
Yes.
um, I don't know, there were like lots of people there. So I know perfectly Gainesville, and it's an excellent word. And what do you think about? First, congratulations,
Thank you.
because you analyzed so many fecal
It's a lot. Yeah. I had a GI
samples that
fellow who
I have
helped a
to
lot.
congratulate you.
Thank
And
you.
second, what do you think? I know that progression is very important when fecal elastase went down, which means a lot. But what do you think? Do you think that exocrine pancreas is involved since or before the diagnosis of type 1 diabetes and is part of the type 1 diabetes, of pre-diabetes? How can you explain us the physiologic mechanism or what you think? I don't know. I don't know a lot about it.
Yeah, yeah. So we're still trying to figure it out, which is why, none of us know a lot about it
Yeah,
because it's an
yeah.
unanswered question, I think. I do think so it could be signifying overall just reduced pancreas size. And so maybe that is just a marker for reduced beta cell volume as well. And so it's hard to say if it's, exactly exocrine tissue that is directly influencing the pathophysiology of type 1 diabetes or if it's just another marker because we don't have a great marker of beta cell mass.
Okay.
And so maybe it's just showing that children with a smaller pancreas at birth are at higher risk for developing type 1 diabetes, or maybe it is showing that, exocrine inflammation, potentially there are other studies showing that, um, exocrine tissue can express different cytokines in response to infection and potentially create an inflammatory environment for the beta cells. And so maybe there's some risk where the exocrine tissue is more prone to creating this inflammatory environment, which then leads to autoimmunity of the beta cells. So those are kind of the two, I guess, leading hypotheses right now. But NPOD and other groups are doing a lot more research looking at pathophysiology. It's also hard when they're this young to get good samples and and study
No,
patients at this
no.
time
And
period.
how exact is fecal elastase in fecal samples? I don't know because it's
Yeah,
so
it's
um,
quite variable.
variable.
Yeah,
Yes,
it's
yes.
quite variable, which is why I think it was helpful to look at so many samples because that helped with the variability. Um, it does not tend to, I think like what is it, sensitivity. The sensitivity of the test is good. I would say the specificity is a little bit less good. So
Okay.
you usually, you don't want to get a watery sample. If you get we excluded basically all of the samples that were liquid in our analysis. So you have to
Of
it has to
course,
be
it has to
somewhat
be
formed. Yeah.
concentrated. Okay.
Yeah, exactly. And you have to have a really good technician, which is I had one, like I said, a GI fellow, and she was really good at ELISAs. And she basically ran all of the ELISAs for the study. And so it was very consistent the way that she did it. So you have to minimize variability because it is, it's trying to measure a enzyme in stool, which
Okay.
is, interesting
I
to do.
imagine it's really difficult. And yes, and do you have you seen or did you read lots of papers about I don't know fecal adverse fecals or very greasy fecals? I don't know. You don't say stools, very fecal stools because of exocrine pancreas in type 1 diabetes because most of them are celiac disease. I haven't seen in my whole life an exocrine pancreatic illness in celiac disease. Maybe I missed them. I don't know. Maybe I am a very bad doctor and I miss them. I don't know.
No,
What
I
do you
don't think it's
think?
because I don't think it's because we're bad doctors. I don't, it's not recommended in like ADA guidelines because it's newer to screen for fecal elastase, but I do think maybe we're moving in that direction for people as like a second line test. So say you do your celiac test, the symptoms are a bit different. It is, greasy stools, fatty stools, bloating, those sorts of symptoms. It's a little bit different than celiac, but if say you do a celiac test and it's negative and they're having significant GI complaints, I think it is a good potential second line test in
Okay.
established type 1. So
I'm
after
very
my talk, actually, I had a girl come up to me who had type 1 and she had had these, GI complaints for years, and they had done multiple celiac tests. They were all negative. She'd even had, I think, an EGD and a colonoscopy, and they were both fine. And no one had ever done a fecal elastase. And like I think it was about 5 to 7 years after her symptoms started, somebody finally did a fecal elastase, and it was very low, multiple times. And now she's taking enzymes, and her symptoms are better. So I think it is getting missed sometimes. I don't think it's,
Maybe we don't think about it. That's why.
yeah,
But
yeah.
that's one of the. But I don't know. Maybe but it's not as common as we think because otherwise we had missed lots of people. But it's
Yeah, I
something
think it's
to
mostly
do.
subclinical, and even in the clinical ones, I think a lot of them are mild. And so, even if you don't treat some of these very mild exocrine insufficiency patients, they're probably not having significant problems like maybe a
Maybe
little
yes.
vitamin D deficiency possibly, but the exocrine pancreas has a lot of reserve. And so I think you have to lose like 90% of the tissue before you have really significant exocrine symptoms. So it's a lot of them are subclinical or maybe mild, and
Okay.
it's not super
I
significant.
think it's super interesting. What is your future plan about it? Because you worked so much that I am impressed, and maybe this was an oral, wasn't it?
Yeah.
Was
Yeah.
an excellent oral. And what are your plan, or is your future direction? No, direction. I don't know.
Yeah, so we have two things we want to do. So first, we want to look at whether we can combine fecal elastase or trypsinogen. So there's some serum markers of exocrine function that are
Yes,
easier to measure because they're not stool. So you can just get them on a blood draw, and then they're a little bit less variable. That fecal elastase is a bit all over the
yes,
place. So trypsinogen is less variable, maybe easier to get because it's a blood draw, although that's, depends on the patient, I guess, if they'd rather give a fecal sample or do a blood draw. But
but
we're going to try to get trypsinogen levels in Teddy as well.
Trypsinogen, I don't know how you say. We used we used to measure in fibroquistic, in enfermedad fibroquística, uh, which was, we used to have an X-ray plaque or and we put there just to know if they had it positive or not. I don't know, 40 years ago.
Yeah. Oh, that's so interesting. Yeah,
Yeah.
so that's what we do in the newborn screen actually for CF, for cystic fibrosis here.
CF,
It's trypsinogen.
cystic fibrosis, dyspnea.
Hmm.
But we
Yeah.
used to do it like that 40 years ago in Argentina. So you're going to, because it's part of the exocrine pancreas. So you,
Hmm.
you want to see that in fecal samples.
Well, no,
Yeah.
so in serum. So we're
Ah,
asking
in
Teddy
serum.
for
Okay.
serum. Yeah.
Okay. Okay. Okay.
Mhm.
That
Yeah.
would
And
be more
then
stable, maybe, no?
yeah, more stable and yeah, less variability just inherent to the test. And also, we have all this genetic data in Teddy, so I wanted to also see if there's any sort of genetic markers that can indicate fecal elastase levels, and if these also are a risk for type 1. So kind of seeing genetic overlap maybe between fecal elastase and type 1 risk. Because Kyle Galton is a researcher who's done a lot of work looking at genetic risk in tissue, like basically regulatory elements in tissue. And it looks like there's some regulatory elements that regulate the exocrine pancreas that are risk factors for type 1. So just kind of interested in some of the genetics of all this too. So gonna look at that.
That's fantastic. Well, congratulations for your work because it's fantastic. I like it a lot. That's why I ask you to share these lessons and this investigation with us.
Yeah,
Uh,
well, thank you
and
so
it's
much.
not very, how do you say? It's not very expensive to do fecal elastase, isn't it?
It's not too bad. No, I guess it depends on the lab that you're running it at. Our kit, I'd have to hold on. Let me do the math real quick because we could run 44 samples per kit, and it's about $800 per kit. So what, $18 a sample? So yeah, about $20 a sample or so. Not
Okay.
terrible. Yeah.
Not terrible. For Argentina, it's terrible, but we
Yeah.
can do it. We could do it, I think, that for less than that. But it's
Yeah,
interesting
probably.
because as we are trying to look at pre-diabetes as now and stage one diabetes and autoantibodies, et cetera, it's another way um, to I don't know to maybe to research about it, and it's
Yeah.
not
Yeah.
that expensive. Uh,
Yeah, I mean, it's not ready again. Like, we didn't see a lot of screening benefit with it by itself. So you'd probably have to do it in combination with other
No, no, no.
markers, but it's
We,
something that
we
we're looking
do
at.
we do autoantibodies.
Oh,
So
okay.
we do it. So we have to add maybe the elastase. I don't know. It's a possibility.
Yeah, once I get more data, I can tell you if it would be helpful or not. But yeah, it'd be nice to have a better predictor of who may get, clinical disease within a couple of years rather than giving them this, 10-year window of you might get stage 3 within 10 years. So that's what we're trying to work on. And then definitely in your established type 1 patients, again, if you've done like celiac testing and it's negative and you're not really sure what to do about their GI symptoms, it could be another test you could try.
Okay. The last question, are you working in with Desmond and with the group in Gainesville? Ah, well,
Yes,
I
yeah.
know
So
Michael Hale, so you can say hello to Michael Hale
I
too.
definitely will. Yes, I will. I'll say hi to the whole group. So yeah, Janet is retired now, but she was actually the reason why I went into pediatric endocrinology.
Yes, and
Yeah.
yes, I know Janet is, and well, I knew Dr. Rosenblum before no, he was
Oh,
just
wow.
retired. The year I went there, he was just retired, and then I
Okay.
knew Tori. I don't know, you didn't know her, but Tori
Oh, yeah, I know the name. I don't think I know her, but I know they've talked about her,
was
definitely.
there, and then I went to a diabetes camp with my
Yes.
three children. So I had a great
Oh,
time with them
that's
when I was
wonderful. That's
like
wonderful.
20 years ago.
Yeah, Dr. Schatz, he's kind of retired. He just sort of retired. He's still around. I think he's keeping a little bit of time just so he can mentor people and do things like that. But
I
he's,
don't think he will retire.
I don't know. I can't see him ever retiring either.
No, no, I can't see him.
But he's cut down his time because now he has four grandkids, and then one of his daughters is pregnant, so he's about to have five
Oh,
grandkids. So
that's fantastic. And I know that his son is a medical doctor, isn't he?
yes, uh-huh. Yeah, his son is actually a gastroenterologist.
So
Yeah.
last days is the thing.
Yeah.
Well,
Yeah.
Brittany, thank you very much, and I'm sorry for the delay.
Oh, that's okay. No, no, no problem at all. I just wanted to make sure I was on at the right time.
Oh,
So,
no, it's okay.
okay.
Thank you. Have
Thank
a great
you
day, and thank you very much.
so much. Nice to meet you.
Bye-bye. Thank you.
Okay. Bye.